there is a lot of data that we need to gather, and sometimes it's really difficult to comprehend all of them. So we'll start with initial management. We've talked about oxygen therapy, and that's it's class 1 only if there is hypoxia, respiratory distress, or heart failure. However, if there is none of these, it's class 3 because it causes vasoconstriction and releases free radicals. All of them, they increase ischemia and myocardial injury. In general, all the trials did not show benefit from routine oxygen therapy. In the small AVOID trial, there was increase in infarct size, MI, arrhythmia, and mortality. In the large detox MI trial, there was no benefit and no harm. And in the meta-analysis of 7 randomized trials, there was no benefit, and there was a trend toward harm in terms of mortality, ischemia, and RMI. Again, relief of pain is very important, but morphine may delay gastric emptying. It also causes nausea and vomiting and interferes with antiplatelets absorption. In the crosshead registry, mortality was higher in patients who received morphine. And again, in 2019 meta-analysis, mortality effect is still there, but the evidence was low. However, there was a high level of evidence that it interferes with antiplatelet effect of B2Y12 receptor inhibitors. Nitroglycerin is helpful only to relieve, it has no survival benefit. So how do we choose which reperfusion strategy to use for our patients? There are 2 important factors. One is symptoms duration or time from symptoms to presentation, and second is the expected diagnosis to balloon or door to balloon time. Time from onset symptoms is very important for fibrinolytic therapy, but for PCI, it's not important because for fibrinolytic therapy, after 3 hours, the clot become hard and resistant to fibrinolytic therapy. However, in the first 3 hours, it is susceptible to fibrinolysis. Again, we have to know that damage occurs mostly in the first 90 minutes, then increases slowly over up to 6 hours. And after 6 hours, there is little myocardial salvage. So primary fibrinolytic therapy benefit depends on time from symptoms onset, while PCI does not, because PCI deals with the thrombus mechanically, with the balloon and with the stent, while fibrinolysis, it has to rise the thrombus. And regardless of symptoms duration or time from symptom onset, PCI is always preferred. If we look at the evidence, we find that in meta-analysis of 10 randomized clinical trial, I want you to look at the first table and the second table. Before 2 hours, mortality with fibrinolytic therapy is only 5.4, which is almost equivalent to PCI, but reinfarction is higher. That's why primary PCI is always preferred regardless of time. As the time from symptoms onset increase, mortality increase with fibrinolytic therapy, and also death and reinfarction increase, while with PCI, it is stable. So time from symptoms onset affects fibrinolytic therapy, but not PCI. Again, the second important factor is door to balloon time. Door to balloon time or door to needle time significantly affects mortality, and this is called system delay. Benefit of PCI is lost if the door to balloon time is more than 120 minutes. And this is, of course, depends on the age of the patient and on the location of the MI. If we take patients less than 65, if they present before 2 hours, anterior MI and non-anterior MI loses benefit within almost the same time, less than 1 hour. That's why primary BCI is indicated within 60 minutes. After 2 hours, anterior MI loses benefit faster than non-anterior. That's in young. In elderly, it's the same. But again, at longer time than young. That's because in elderly, when you give fibrinolytic therapy, the complications are high, which makes primary BCI benefit more than young. When they receive fibrinolytic therapy, their complications are less. So it's not because of the age, it's because of the complication of fibrinolysis. Again, risk category, we know that high risk, they benefit more from primary BCI, and this is not relevant now, as we mentioned earlier, because everybody should go to primary BCI. Another point was not clear is the time targets. Maximum time from first medical contact to ECG and diagnosis should be 10 minutes. So when the patient comes with chest pain, ECG has to be done within 10 minutes. I think this is very clear. After that, the zero time starts when the patient is diagnosed. This is the new guidelines. Before, the zero time starts when the patient presents to emergency room, which is door to balloon. So now we are not talking all the time. We'll mention is diagnosis to BCI or to fibrinolytic therapy rather than door to balloon or door to needle. So maximum time to choose PCI, whether inside or transfer over fibrinolysis, is 120 minutes. And this time is based on 30 minutes for door in, door out in the referring hospital, 60 minutes for transfer, and 30 minutes for receiving in the other or in the primary BCI center. So the total time is 120 minutes. If it exceeds that, you fibrinolyze the patient. If you can achieve it within 120 minutes, you transfer for PCI. Of course, if you cannot meet this, you still give fibrinolytic therapy and transfer, and this is fibrinolytic pharmacoinvasive therapy. As I mentioned last time, the choice of treatment now is not fibrinolysis or PCI, it's pharmacoinvasive or PCI in everybody. The rationale is that primary BCI loses benefit at 120 minutes, as we know in randomized clinical trial and registries. And pharmacoinvasive overcome this disadvantage of primary BCI transfer delay. So the time target, if you are in a BCI capable hospital, the time target is 60 minutes. As we said, because of loss of benefit is early, especially in young. If you are transferring the patient, the time target to wire crossing is 90 minutes. And this because you already excluded the first 30 minutes for door in, door out. So door in, door out is out of this 90 minutes. This is, of course, different from door to balloon, especially in patients who present in PCI capable hospital, where door to balloon is 90 minutes, but in diagnosis to balloon or wire is 60 minutes. And why is that? Because mortality increase as door to balloon increase from 3.5 to 8.4, which is almost triple when the time increased to 180 minutes compared to 60 minutes. Again, fibrinolytic therapy is only given before 12 hours of symptoms, during the first 12 hours of symptoms onset. If the patient present after 12 hours, there's no fibrinolytic therapy. And maximum time from diagnosis to infusion or bolus of fibrinolytic therapy is 10 minutes. This is called diagnosis to needle time, which is different from door to needle time. Door to needle involves diagnosis, history, examination, ECG, bloods, and so on, plus the time needed to prepare the medicine, which is almost 30 minutes for door to needle, while door to diagnosis is only, diagnosis to needle is only 10 minutes. And this is based on STREAM trial, where the bolus was given within around 10 minutes. Again, the reason is that fibrinolytic therapy loses benefit faster than primary PCI. Again, after you fibrinolyze the patient, within 60 to 90 minutes, you have to assess him whether he responded, it was successful or not. And again, after that, you transfer all patients to primary BCI center. So it's not you give only fibrinolytic therapy and you said, no, you have to assess the effect within 60 to 90 minutes and the effect, and then you have to transfer him for for BCI post fibrinolysis. So if we consider strategy according to time of presentation, if the patient presented within 12 hours, which is the early phase of MI, either you treat him with primary BCI, which is preferred, or fibrinolysis if you cannot achieve the time target we already discussed. After 12 hours, there's no fibrinolytic therapy, as we mentioned earlier, only primary BCI. And it depends whether it's more than 12 hours with symptoms or without symptoms. If with symptoms, regardless of time, whether 12 hours, 48 hours, 72 hours, you still triage him to primary BCI. If the patient is asymptomatic, it's only BCI as primary is indicated only in the first 12 to 48 hours, while contraindicated after 48 hours. And this summarizes all what we said. So let's look at the first 12 hours. Primary BCI is class 1A, and fibrinolysis is class 1A only if primary BCI cannot be achieved within the time target, whether in the first 3 hours or in the first 12 hours. So up to 12 hours, you have two options, primary BCI or fibrinolysis. After 12 hours, you have only one option, which is primary BCI. If the patient presents with a 12 to 48 hours with symptoms, without symptoms, it's primary BCI is indicated even if he's asymptomatic. After 48 hours, if asymptomatic, it's contraindicated. If he's symptomatic, regardless of time, you see whether it's 12 hours or endless, you still triage him to primary BCI. I hope this point is clear. So less than 12 hours, you fibrinolyze. More than 12 hours, no fibrinolytic therapy because it is not effective in reducing mortality and it has high complication rate. So why primary BCI is preferred over fibrinolytic therapy in the first 12 hours? Because outcome is better regardless of symptoms duration. Less than 2 hours, primary BCI and fibrinolytic therapy has equal mortality as we saw in the previous slide. Okay, but reinfarction and MI is higher with fibrinolytic therapy compared to primary BCI. After that, mortality increase in fibrinolytic therapy, but not in MI. And again, if we see in meta-analysis of trials, primary BCI reduces mortality by almost 34% compared to fibrinolytic therapy after 2 hours of symptoms onset. And this is what we see again in the two tables. So there's significant reduction in mortality with primary BCI, which increased with increasing time of symptoms duration. Again, the second reason is that there are many limitations of fibrinolytic therapy. One of them is that benefit is time dependent and there's no significant benefit after 6 hours. It fails in almost quarter of patients. There is high incidence of recurrent ischemia, reocclusion, and reinfarction. It achieves TIMI-3 flow on only half of the patient, which is correlated with mortality benefit. There's high risk of bleeding, and many patients are not candidate for fibrinolytic therapy. And again, benefit is not documented, as we mentioned earlier, in CABG and cardiogenic shock. After 12 hours, there is only primary BCI, as we said, no fibrinolytic therapy. Why? Because clot is resistant to lysis. there's no mortality benefit, and there was increased harm in the trials that gave fibrinolytic therapy after 12 hours, especially intracranial hemorrhage. And late presenters again were excluded from major randomized clinical trials. So if patient is symptomatic, regardless of symptoms duration, you take him for primary BCI. After 48 hours, BCI is contraindicated in stable and asymptomatic patient. This is based on multiple trials, TOT, TAMI 6, and Swiss trials, because there was no benefit and there was higher MACE. And as we mentioned last time, the best evidence comes from OAT trial, which is occluded artery trial. BCI did not reduce occurrence of death, reinfarction, or heart failure, and it was associated with harm. I think this morning we came across a case like that where the patient presented, had presented late, I think, to Shemesi Hospital. Anyway, probably we'll discuss this later. Now let's come to a typical presentation, which is ST elevation MI in disguise, or ST elevation MI equivalent. As per the guideline, primary BCI is indicated if there's ongoing ischemia and atypical presentation. And atypical means the ECG is not diagnostic of ST elevation MI criteria. And there are many causes for atypical presentation, and the incidence is around 25% of patients with ST elevation MI. This includes left bundle branch block, base rhythm, De Winter wave, left main occlusion, hyperacute T wave, and posterior MI. And high-risk patients are Wellens, you triage them like non-STEMI, while the above, you triage them like ST elevation MI. And I think we came across these diagnoses in the first few lectures where we were talking about diagnosis of ST elevation MI. For left bundle branch block and base rhythm, there's no indication for primary BCI except if the patient has ongoing ischemia or unstable. Unstable means hypotension, pulmonary edema, or arrhythmias, or if the Scarboza or modified Scarboza criteria are satisfied. These are the only three indications to triage the patient to the cath lab. However, if there's no evidence of these three, even if the left bundle branch block is new, you don't triage him as ST elevation MI. Again, De Winter syndrome, which is proximal occlusion of the or threatened occlusion of the proximal LAD. It was described in 2008. It was not known before. And these patients, again, should be treated like elevation MI. ST elevation in AVR with diffuse ST depression is not equivalent to left main occlusion, because left main occlusion usually presents with cardiogenic shock or cardiac arrest. And in a recent trial, a large trial, left main occlusion was seen only in 10% of patients with ST elevation in AVR with diffuse ST segment depression, while the remaining patients, they had severe three-vessel disease with intact distal flow, and 40% had mild to moderate disease, and it was type 2 MI, which is MI due to non-cardiac causes. So ST elevation in AVR, you don't triage them like STEMI, you rather treat them like non-STEMI with urgent cath, because most of them, they will require CABG because of diffuse three-vessel disease. Again, another mimicker, which is hyperacute T wave, and we know that the first sign of ischemia is QT prolongation, then hyperacute T wave. However, you have to remember that there are many causes of hyperacute T wave you have to rule out. So what to do in these cases? You repeat the ECG every 20 to 30 minutes until either you reach a diagnosis as STEMI or non-cardiac diagnosis. Now we'll come for the second option, which is fibrinolysis. As we mentioned earlier, it should be given within less than 10 minutes from diagnosis of STEMI or door to needle less than 30 minutes. And again, remember that all patients must go for PCI after fibrinolysis, which is pharmacoinvasive strategy. The rationale of giving fibrinolytic therapy comes from old trial where there were significant reduction in mortality in patients who received compared to patients who were treated with conservative therapy. And again, you have to assess the effect within 60 to 90 minutes, whether it was successful or not successful. And the criteria for successful is one, disappearance of chest pain within 90 minutes of starting fibrinolytic therapy, resolution of ST segment elevation more than 50%, earlier and higher peak of cardiac troponin, and other non-specific signs which we call reperfusion arrhythmia, which is not considered. So the most important is that the chest pain disappears and the ST segment resolute more than 50% compared to maximum ST elevation. So in the guidelines, it's class 1 indication if you cannot do PCI within 120 minutes, and it has to be given as soon as possible and preferred in pre-hospital setting. You have to use fibrin specific agent like tenecteplase, alteplase, or retiplase instead of streptokinase. And in elderly, you use half dose tenecteplase to avoid intracranial hemorrhage. We'll go across the evidence of one by one according to the guidelines. So if timely primary PCI cannot be performed, you thrombolize the patients only if he presents within 12 hours. After 12 hours, no fibrinolytic therapy transferred to PCI. And the evidence or the basis of this recommendation is that less than 10% of patients can achieve door to balloon less than 90 minutes in transferred patients. In NERMI registry, advantage, as we mentioned last time, of PCI is lost after 120 minutes, and primary PCI again for anterior MI is lost at 60 minutes. And in meta-analysis of 21 randomized trials, advantage of PCI is lost at 110 minutes delay. That's why if the delay is 120 minutes, you thrombolize the patient. Again, it has to be given as soon as possible because of the limitations of fibrinolytic therapy we discussed earlier. The earlier, the better. And the best evidence comes from STREAM trial. When you fibrinolyze the patient earlier, the outcome is equivalent to primary PCI. This is when the patient present within 3 hours of symptoms duration. However, this strategy, of course, is not practical because we don't have pre-hospital fibrinolysis here. But again, this trial gives you an indication that fibrinolysis is equivalent to fibrinolysis plus primary PCI, which is pharmacoinvasive, is equivalent to primary PCI. And remember, in this trial, emergency coronary angiography was required in almost 37%. So failure was very high for fibrinolytic therapy. That's why they went for rescue or emergency PCI. Fibrin-specific agent is again class 1, and this is based on meta-analysis of multiple randomized trials where streptokinase and non-accelerated TBA were significantly associated with increased mortality compared to other fibrin-specific and accelerated TBA. There's no mortality difference between the 3 fibrin-specific agents. However, TNK, which is tenecteplase, has the lowest incidence of bleeding. So that's why it's preferred in most centers and most guidelines. In elderly, as we mentioned earlier, you give half dose of fibrinolytic therapy. Okay, then what to do after fibrinolysis? Okay, you have to shift the patient routinely for coronary angiography. And this is what we call drip and ship. And this is only if anticipated delay in primary PCI is more than 120 minutes. So you fibrinolyze the patient and you transfer him to PCI between 2 and 24 hours. The rationale is that it reduces infarct size and improves outcome, including mortality. And we'll talk about this later on. So there are two types of one of them is pharmacoinvasive strategy. And this strategy includes routine PCI and emergency or rescue PCI and urgent PCI. So it includes all the three. It includes routine PCI if the fibrinolysis was successful, and includes rescue PCI or urgent or emergency PCI if fibrinolysis was not successful or failed. The second strategy is facilitated PCI, and this one is class 2 in the guidelines. The difference between them is the timing. Pharmacoinvasive is after 2 hours. Facilitated is within 2 hours of fibrinolytic therapy. And the reason is that it's associated with higher risk of bleeding and mortality and arrhythmia and distal embolization. Why do we transfer patients? It's because of, again, what we mentioned earlier, the limitations of fibrinolytic therapy, which includes failure, threatened reocclusion, reinfarction, and only 50% achieve STEMI 3. And that, again, outcome is related to STEMI 3 rather than STEMI 1 or 2 or even 0. So there's big difference in outcome between STEMI 3 and STEMI 1, 2, or 0. And this was clearly shown in GUSTO-1 trial, where STEMI 3 is the only one associated with survival benefit, while no survival difference between STEMI 0, 1, and 2. Again, transfer to PCI capable hospital is class 1, and angiography plus minus PCI is class 1. Now we will discuss the evidence according to the other strategy which it was compared to. So pharmacoinvasive was compared to primary PCI, and it was compared to conservative management or ischemia guided PCI. The best evidence comes again from STREAM trial, which compared pharmacoinvasive versus primary PCI. And the final conclusion is that there was no difference in MACE or all-cause mortality at 1 year. Okay. However, you have to remember again that emergency angiography and PCI was required in almost 1/3 of patients. So don't think that pharmacoinvasive is better than PCI. It's non-inferior to PCI if it's applied in the right way and according to the recommendation, which means you fibrinolyze and you ship immediately for PCI. So it's not better than PCI. It's non-inferior considering the high crossover, which is high rate of emergency PCI. The second comparison was pharmacoinvasive versus ischemia guided, which means you do stress test or thallium and you decide whether the patient will go for PCI or not. And this was evaluated in many randomized clinical trials, almost 9. The final conclusion is that of these trials, pharmacoinvasive was associated with reduced short-term mortality, reinfarction, recurrent ischemia, and heart failure without increase in major bleeding. And based on these trials and meta-analysis of these trials, the 2017 guidelines recommended pharmacoinvasive as class 1 level of evidence A. If we look at these trials, you find, again, there's no difference in mortality. However, there was significantly lower infarction and ischemia, And this was maintained at long-term follow-up. Why there was no mortality benefit, we will discuss this later on. And the evidence or the benefit was confirmed in 2010 meta-analysis and 2011 meta-analysis. In both, there was no mortality benefit, but there was reduction in reinfarction, reischemia, heart failure, and better LV function. So why there was no mortality benefit in these old trials, while in STREAM there was a mortality benefit which was comparable to primary BCI, is that in most trials, therapy was given after 3 hours of symptoms onset, where the clot becomes more resistant to fibrinolysis. And the best evidence of this timing comes from the FAST MI program. Patients who were treated with fibrinolytic therapy within less than 90 minutes had 5 years survival equivalent to primary BCI less than 120 minutes, which is exactly the same like STREAM trial, and much better than BCI more than 20 minutes. And this is again the recommendation to use pharmacoinvasive therapy. In patients treated after 90 minutes of symptoms onset, pharmacoinvasive survival is like primary BCI after 120 minutes. So survival is improved if fibrinolytic therapy is given within less than 3 hours. And again, why did the guidelines choose the 2 to 24 hours window for PCI after fibrinolysis? This comes from multiple trials, including Capital Acute MI, SIAM, West, Nord, STEMI, CARES, Transfer Acute MI. In these trials, the average time was 2 to 17 hours. And meta-analysis of all of them, they found that if you do coronary angiography less than 2 hours, there was no benefit, and there was a trend toward higher increased risk of bleeding. However, if you do PCI, so there's no mortality benefit when you do coronary angiography and PCI within 2 hours of fibrinolytic therapy. However, after 2 hours, there was lower 30 days death, reinfarction, and recurrent ischemia, and this was maintained at 1 year. Based on this, that benefit exists when you do PCI after 2 hours, not before 2 hours. The guideline recommends the window of 2 to 24 hours for pharmacoinvasive strategy. I mean BCI after fibrinolytic therapy. And that's based on the time window which was in the trials used in this meta-analysis. So routine PCI we've already discussed, and we know that it reduces mortality when it's given in the right time or in the first 3 hours. It reduces reinfarction, threatened occlusion, reischemia, and improves LV function compared to ischemia-guided or conservative therapy. And it's equivalent to BCI, primary BCI, when it's used within the first 3 hours of symptoms duration, as in STREAM trial. Now we'll come at rescue PCI, which is part of the pharmacoinvasive. As I mentioned, if you look in pharmacoinvasive therapy strategy in STREAM trial, 36% they required emergency PCI. So rescue PCI or emergency PCI is part of pharmacoinvasive strategy. It's not a different strategy. Rescue PCI by definition is emergency PCI for failed thrombolytic therapy, while urgent is PCI for reinfarction, reischemia, or reocclusion, or hemodynamic instability. In the guidelines, rescue PCI is class 1 level of evidence A, which means there's high level of evidence of benefit. And the evidence comes from multiple trials. As we mentioned earlier, the incidence of failure, primary failure, is almost a quarter in patients with fibrinolytic therapy is a quarter of patients, or 27%. And the definition, clinically, it's defined as failure to achieve more than 50% ST segment resolution. and or persistent chest pain or hemodynamic or electrical instability. Any of these defines clinically fibrinolytic therapy failure. And by angiography, persistent occlusion of the infarct-related artery, i.e. TIMI 01 or 0 or 1. And this occurs in 40 to 50% of patients. And definition of rescue PCI is that PCI within 12 hours of failed fibrinolytic therapy. After 12 hours, again, it's useless because the patient already lost most of his viable myocardium. And several trials looked at the benefit of rescue PCI, includes Rescue, Merlin, and React trial. In these trials, there was 3 arms or 3 management strategies. One is to take the patient for primary PCI. Again, the second is to compare primary PCI or repeat fibrinolytic therapy, or just to treat him with conservative therapy. In these patients, there was no significant difference. There was significant reduction in heart failure, reinfarction, and trend toward reduction in mortality with rescue PCI. However, mortality was not significant because most of the trials were old and they used no B2Y12 inhibitors. Most of the treatment was balloon angioplasty, and we know that acute occlusion after balloon angioplasty occurs in almost 40% of patients. There was long time from failure to PCI, more than 4 to 6 hours, and there was high use of glycoprotein inhibitors. That's why there was no mortality benefit. However, there was significant reduction in the infarction and heart failure, and significant improvement in LV function with rescue PCI. The best evidence comes from React trial because they used stents, they used antiplatelets, clopidogrel, and they compared repeat fibrinolytic therapy, primary PCI, or conservative management. At 6 months, there was significant reduction in mortality and all MACE in patients who went for primary PCI. And the survival was 85% at 6 months with rescue PCI, while there was no difference between repeat fibrinolysis and medical therapy. So repeat fibrinolytic therapy for failed fibrinolytic therapy is useless. You don't have to consider this. And again, this mortality benefit was maintained at long-term follow-up. In another observational trial, MACE was 24% with rescue PCI versus 36.5 with repeat fibrinolytic therapy or conservative or medical therapy. So there was significant, again, reduction in mortality. While in the old trials, we mentioned why there was no significant mortality benefit. So again, if you compare repeat fibrinolysis versus conservative therapy, there is no difference in outcome, and it's not indicated, it's rather contraindicated as per the guidelines. So in summary, rescue PCI is the treatment of choice for failed fibrinolytic therapy. Transfer to PCI as soon as possible at approximately 45 to 60 minutes following fibrinolysis will avoid delay in treating these patients. As I mentioned again, almost 36% in STREAM trial, they failed fibrinolytic therapy. That's why you have to recommend transfer immediately after fibrinolytic therapy for PCI. PCI or CABG should be done even in patients with TIMI 3 because observational data showed improved outcome with PCI in patients with TIMI 3 after fibrinolytic therapy. So when you find a lesion, the flow is TIMI 3, you still stent that lesion despite the good flow because outcome is better after stenting than after conservative management. Again, in case of threatened reocclusion or reinfarction, emergency PCI is indicated as class 1. And we'll talk about the definition and evidence. The definition of threatened reocclusion is early recurrent ischemia after successful fibrinolysis. Reinfarction is acute MI that occurs within 28 days of the first MI. Of course, with fibrinolytic therapy, it's within the first 12 hours. Recurrent ischemia is different from recurrent MI. Diagnosis is totally different. Diagnosis of reinfarction is that there will be a new or recurrent ST elevation more than 1 millimeter. So if the ST elevation is persistent or decreased little bit, re-elevation more than 1 millimeter will diagnose recurrent infarction. There will be recurrence of chest pain, elevation of cardiac troponin more than 20% if baseline is elevated but stable. If baseline is normal, which does not make sense according to the MI criteria. So you use the ECG, the chest pain, and the recurrent enzyme elevation. This is the fourth definition of ST elevation MI or acute MI. According to the American guidelines, they use the same thing, but they use more than 50% elevation rather than 20% elevation as criteria. So the incidence is different in different trials. Threatened reocclusion occurs in about 20 to 30% clinically and by ECG criteria. In thrombotic reocclusion, which is documented by cath lab, is 5 to 15%, and reinfarction is 3 to 5%. Again, in STREAM trial, the incidence of these three plus failure of fibrinolytic therapy was 36%. The outcome is that it's associated with significantly increased mortality and heart failure. And this was shown in multiple trials that mortality is much higher in patients with reinfarction. It goes up to 16% versus no reinfarction, which is around 3.5 to 6%. The treatment of choice is primary PCI. If you cannot do primary PCI, you are in a peripheral center, then you thrombolize the patient. Compare this to what we mentioned earlier, which is fibrinolytic therapy failure. There's no repeat fibrinolysis, while here you can use fibrinolytic therapy again, because both reduces mortality and improve LV function. And evidence comes from multiple trials where PCI and CABG significantly reduced in-hospital mortality by 78%. It was 5.6% with PCI versus 24% with medical therapy. Again, in GUSTO-1 and ASCENT-2 trials, 4% had reinfarction. Revascularization reduces 30 days mortality by 61%. For these reasons, it's class 1 in the guidelines that you take the patient for PCI. If you cannot, then you give fibrinolytic therapy. For fibrinolysis, there is no randomized clinical trial. However, in most trials, they used, again, TBA. SK should be avoided in these patients because of antigenicity. And again, the patient will be resistant if you give him initial SK. But in most patients, rarely you need to give repeat fibrinolysis. So for threatened occlusion, reinfarction, the options are either primary PCI again, or fibrinolytic therapy. And failed fibrinolysis, the only option is primary PCI. And again, the evidence comes from, as I mentioned, from GUSTO-1 and from ASCENT-2 trials. They use three strategies: PCI, repeat fibrinolysis, or conservative therapy. At 30 days, there was no difference in mortalities between repeat fibrinolytic therapy and primary and PCI. In both, it was 11%. In both, mortality was lower than conservative, which is 11 versus 28%. That's why the recommendation is to do primary PCI. If you can, then you thrombolize the patient with equivalent outcome in both compared to medical therapy. I don't know what time is it. Okay, we have 13 minutes to go. Of course, as we mentioned, streptokinase should not be used for several reasons. First, it's derived from bacterial protein, and it's highly antigenic. Naturally, some people will have neutralizing antibodies because of previous streptococcal infection, and they are allergic to streptokinase. Again, benefit is limited because of high resistance of the clot to streptokinase because it's not specific. And for these reasons, it's not recommended in the guideline to use streptokinase either as primary fibrinolysis or as repeat fibrinolytic therapy. So in summary, threatened reocclusion or reinfarction with hemodynamic compromise, you insert an intra-aortic balloon pump and you shift him to revascularization. Recurrent ischemia or reinfarction without hemodynamic compromise, immediate PCI if you can. If not, then you fibrinolyze the patient. Again, the time window here is 2 hours, by the way, which is 120 minutes like the initial presentation. Patient who receive repeat fibrinolytic therapy should be observed for stability, and again should be shifted for PCI after repeat fibrinolysis. If symptoms recur, again, angiography and coronary intervention is recommended. Okay, what about patients who present with heart failure or cardiogenic shock? Again, these patients, primary PCI is indicated rather than fibrinolytic therapy because there's no study or no benefit from in these patients. You need very good blood pressure to deliver the therapy to the artery. If the patient is hypotensive, then very little fibrinolytic therapy will reach the clot and definitely will not lyse it. The evidence is mainly expert opinion. There's no dedicated randomized clinical trial. And the recommendation is based on REACT trial, which is fibrinolytic therapy failure, where shock and heart failure incidence was decreased with PCI compared to conservative management with fibrinolysis. And again, in this trial, patients with hemodynamic compromise or shock, they had improved survival. And again, in shock trial, patients with hemodynamic compromise had improved survival compared to conservative therapy with primary PCI. We'll talk about facilitated PCI. Again, this is PCI within 2 hours rather than after 2 hours of fibrinolytic therapy, and it's class 3 in the guidelines. There are several regimens of facilitated PCI which was tested: full dose IV fibrinolytic therapy, combination of fibrinolysis and glycoproteins or glycoproteins alone, and then the patient was taken for PCI within 2 hours. And there are multiple trials. If you look, the time from therapy to PCI was always less than 2 hours. And they found that immediate PCI after fibrinolysis is associated with increased mortality, reinfarction, and bleeding compared to primary PCI. It will come immediately to your mind, what's the difference between this and that? It's only the timing. The reason is that in the first 2 hours, fibrinolysis increases platelet activity and platelets coagulation. Again, it lyses the thrombus, it releases fibrin and fibrin and activate thrombin again to initiate more clot. Again, when you take the patient early, there will be more distal embolization, which causes an infarction and microvascular obstruction, and higher risk of no reflow. And again, the third reason is increased bleeding, which is always associated with increased mortality. So if you take them within the first 2 hours, there will be higher thrombus, higher distal embolization, higher microvascular obstruction, higher no reflow phenomena, and higher bleeding, all of which leads to higher mortality and reinfarction. While after 2 hours, all of this will be stabilized, especially with anticoagulation, and the risk is much lower. That's why BCI after 2 hours leads to improvement in survival and outcome. These are the trials that looked at facilitated BCI, and I think it's not important now. You only need to know that facilitated BCI is harmful. In meta-analysis of 17 facilitated trials, despite higher TIMI flow, facilitated BCI increased the risk of death, infarction, urgent revascularization, also stroke, whether embolic or hemorrhagic. However, we have to know that these trials, they were old, and plain old balloon angioplasty was used rather than stents. Routine antiplatelets were not used, which are the new ones. That's why it failed to show benefit. Maybe again, that's why there was higher risk of reinfarction and death. So the current recommendation is that facilitated BCI should be avoided because of significant increase in mortality. Facilitated fibrinolytic therapy also increased the risk of free wall rupture. When we come to complication of MI, you will find that one risk is fibrinolytic therapy. And regardless of the strategy of facilitated BCI, it is not recommended, whether with full dose, half dose, or with glycoprotein inhibitors. Thank you. And probably next time we'll continue with another subject, which is procedural management during primary BCI. Okay, is there any question? I hope this presentation was clear. I know it's difficult and really confusing, but I hope it was useful.
يعطيك العافية دكتور. Yes.
Any question?
هو بس one question دكتور. طيب لو البيشنت مثلا زي جانا كيس في اليار مثلا 6 hours he was diagnosed and then STEMI, هو كان جايب 4 hours or 5 hours of chest pain وCG كانت normal, لكن after 2 hours of presentation he had dynamic changes of ST elevation. Should I consider since the beginning of chest pain the 0 time or the ST elevation?
No, always the 0 time is the diagnosis, which is the ST elevation by ECG. Anything before that is not considered. And again, the reason, because it's not fair for you, to take the burden of the time before the ST elevation in my diagnosis, whether it's system delay or patient-related delay. With symptoms duration is the patient-related delay. And the initial delay before diagnosis is the system delay. So your 0 time as a cardiologist start from diagnosis by ECG. Okay. This is your 0 time. Any other question? Okay, if there's no more questions, probably we'll meet next week, inshallah.